now be recorded.
Hello friends. Before we start today's session, I would like to thank RK University Rajkot for organizing this webinar, and my special thanks to Dr. Priyanshu Rathore sir and Dr. Nidhi Ved for giving me this opportunity to conduct this webinar. So today's session, it is Electrodiagnosis Reading a Report by me, that is Dr. Ashish Kakkad, SPB Physiotherapy College, Surat. Now, let us start with classification. So this lecture is designed in such a way that even if you don't know how to perform electrodiagnostic test, especially it is for EMG and NCV, because we are getting exposure of performing EMG NCV in masters only. But many times it is possible that even as a bachelor, when we are practicing, so at that time we are getting these reports in our hand. So it will be very difficult for us to interpret them. So after this lecture, it will be easier for you. So let us start with classification of this electrodiagnostic test. So they will be classified into two. One is traditionally used and one is with recent advances. So traditionally used, we all know, that is strength duration curve and Faraday galvanic test. So we will not go in more detail about this traditionally used test. Okay, and recently used test. So they are EMG, NCV, mostly we are calling it. So EMG means it is electromyography. So the name itself, it is telling that it is recording of the electrical activity occurring in muscle. That may be by needle, okay, so that is invasive, and it may be by surface electrode also, so it is non-invasive. Now that was regarding muscle. Now what about nerve? So for now we have test that is known as NCV, nerve conduction velocity. It may be of motor nerve, it may be of sensory nerve. Okay, now muscle now. So what about neuromuscular junction? So for that we have RNS, that is repetitive nerve stimulation. So if you suspect any patient with myasthenia gravis or lumbar titan myasthenic syndrome, you need to go for RNS. Okay, then you will be having late responses. Okay, for example, peripheral nervous system is over and central nervous system is starting. So the interface is there between the central nervous system and peripheral nervous system. So that is nothing but roots. We are telling, like for example, if the patient is having radiculopathy, so that is problem at root level. So for that we have H reflex and F wave. Clear? And for central nervous system also we have a few tests. So those are known as evoke potentials. So evoke potentials may be of motor pathway, sensory pathway, visual pathway, auditory pathway. But frankly speaking, practice of evoke potential is very less in the market. But rest all other tests, they are practiced nowadays also. Clear? So we have strength duration curve first. So many times I have seen that we are confused after performing SD curve, but no need to confuse. Okay, there are only three possibilities. Okay, only three possibilities of interpretation. One is fully innervated muscle, so that is normal. Another is partially innervated muscle. Okay, means few muscle fibers they are having nerve supply, few muscle fibers they don't have nerve supply. So that is partially innervated. And another is fully denervated, means there is no single muscle fiber that is supplying your muscle. Clear? So for clinical aspect, normal or fully innervated muscle, for that we are using the word normal. For partially innervated muscle, we are using the terminology that is PRD, that is partial reaction of degeneration. And for fully denervated muscle, we are using terminology CRD, that is complete reaction of degeneration. Clear? So normal, PRD and CRD. Clear? Now, normal or fully innervated. So the curve is towards left side and downwards. Why it is towards left side? Because with minimum pulse duration also you are getting response. Okay. Why it is downwards? Because with minimum intensity also you are getting response. Clear? So it is towards left side and downwards. Clear? Because we have response with minimum pulse duration as well as with minimum intensity. That's why. Now exactly opposite of this, that is CRD, complete reaction of degeneration, means there is no single muscle fiber that is supplying your, there is no single muscle fiber that is getting nerve supply. Means all the muscle fibers, they are denervated. All the muscle fibers, they are not having any type of nerve supply. Clear? So it is towards left and upward. Okay. Why upward? Because with minimum intensity, we are not getting response. Why it is towards right side? Because with minimum pulse duration, we are not getting response. Clear? So this is why it is right side and upward. Then comes PRD, that is partial reaction of degeneration. So in this, you can see there is kink. So one graph is towards right side of the kink and one graph it is towards left side of the kink. So the graph that is on the right side, that will be because of denervated as well as innervated fibers. But the graph that is on the left side, that is because of only innervated fibers. Why? Because on left side you can see that pulse duration is low. Okay, so definitely the denervated fibers will not be responding. Only there will be response from innervated fibers. Clear? So the kink right side, it is because of innervated as well as denervated fibers. Left side, it is only because of innervated fibers. Clear? Okay, so as the recovery advances, the kink will shift and the portion of innervated fibers will increase. Clear? Okay. Then second test, it is Faradic galvanic test. It is also known as reaction of degeneration test. It is also known as Faradic interrupted direct current test. So interrupted direct current, it is nothing but Faradic current only. Clear? So here the muscle will be stimulated with IG, that is intermittent galvanic current, as well as with SF, that is surge Faradic current. What will be the responses? So mathematically, there are four probabilities. Clear? Ig positive, SF positive, Ig positive, SF negative, Ig negative, SF positive, and Ig negative, SF negative. So here, how this currents will be stimulating muscle, that we need to learn. So Ig may stimulate the muscle directly because of its long pulse duration. While the SF cannot stimulate muscle directly, SF will stimulate the nerve, and that stimulated nerve will stimulate the muscle. Clear? So it's like a simple example. You have tube light. Okay, so when you switch on, at that time the current will be passing from the wire, and that wire will be supplying the tube light, and tube light will glow. Clear? And another thing, wire is not working. So even if the bulb is working or tube light is working, it will not be on. Why? Because you are giving stimulus through wire. Clear? But if you are directly stimulating with battery, okay, directly when you apply the potential difference by the battery in the tube light, so definitely it will be on. So the similar things we are doing here. One, we are stimulating by now, that is by the use of SF, and one we are stimulating directly muscle. Clear? So Ig positive, first probability, means muscle is functioning. SF is positive, means now and muscle both are functioning. So definitely reaction of degeneration is absent. Now second possibility, so that is Ig positive, SF negative. So Ig positive, what does it mean? Muscle is functioning because Ig will stimulate muscle directly. SF is negative. So SF negative means what it tells, either the muscle is not functioning or nerve is not functioning or both are not functioning. Like in our example, when you switch on, so if the tube light is not on, so either there is problem in tube light or there is problem in wire or in both. So tube light is our muscle, wire it is our nerve. Clear? Okay, so there may be problem in muscle, there may be problem in nerve, or there may be problem in both. But in the same patient, you are telling in the same muscle Ig is positive, means muscle is functioning. Clear? So now initially we thought of three possibilities: either the muscle is not functioning or nerve is not functioning or both are not functioning. But here muscle is functioning. Okay, so definitely the nerve is not functioning. Definitely we can also exclude that option, that both are not functioning, because we know that Ig is positive means muscle is functioning. That's it. So Ig positive, SF negative means there is no problem with muscle, the problem is with nerve. So the reaction of degeneration, it is present in the nerve. Third option, that is Ig negative, SF positive. Now here in third option, SF positive, what it tells, SF positive, it tells that nerve is functioning, muscle that is also functioning, means both are functioning. But Ig is telling that muscle itself, it is not functioning. Clear? So just imagine the tube light is not functioning. Clear? Tube light itself, it is not functioning. So even if your wire is functioning, it's useless. Clear? So here, even if your nerve is functioning, but tube light itself, it is not working in our example, means here the muscle is not working. Clear? So what is happening? Even though nerve is functioning, muscle is not functioning, so there will not be response. Clear? So actually third probability is not possible. Clear? Because SF positive itself, it is telling both are functioning, and Ig itself, it is telling muscle is not functioning. So this is not possible. It is just mathematical probability. Then fourth probability, Ig negative. Okay, means in our example, tube light itself, it is not working. Okay, so definitely when you stimulate by wire, then also it will not be working. So Ig negative means muscle is not functioning. SF negative means muscle is not functioning. So even though your nerve is functioning, you will not be getting response. Clear? So in both the cases, it will be negative. Negative means no response. Clear? So Ig negative will be present in case of muscle contracture, ischemia, or fibrosis. Clear? Because excitability of the muscle will be lost in case of contracture, ischemia, and fibrosis. Now, so we were knowing that part, whatever we discussed till now, but this is something advanced, so we can understand. So first we will get idea regarding nerve conduction study. Okay, so nerve conduction study will be used for assessment of peripheral nervous system. Okay, it is purely for peripheral nervous system. Clear? There were two limitations, if you remember, for the SD curve. SD curve gives us qualitative data. It is not giving us quantitative data. Like if you say that muscle is having partial reaction of degeneration, so it is not telling that how many fibers are denervated, like 42%, 45%. It is not possible to quantify. It is just giving you qualitative data. Okay, that this is PRD, this is CRD, this is normal. But in case of NCB, you can identify that how many percentage of axons are affected. Clear? As well as this will give you quantitative data like now conduction velocity 52.24 meter per second. So it is giving in numbers, it is giving in digits. Clear? So it is giving you quantitative data. SD curve was not able to localize the site of lesion. By this NCV, you will be able to localize the site of lesion also. Now, this is recording circuit. Okay, so you can see patient is in comfortable position, and whatever it is in my hand, it is stimulating electrode. Whatever you can see with this green color, it is known as ground electrode, and these two are recording electrodes. One is of black color, that is cathode by polarity, and red color, it is anode by polarity. Let us have a close-up view. So these are the surface electrodes. They are also known as button electrodes because they are very small. Okay, diameter is generally about 3 to 5 mm, and they are made up of silver chloride. So polarity, as we discussed, black will be cathode and red will be anode. So black will be working as recording active and red will be working as recording reference. We are not discussing placements. Okay, this is just for idea. These are sensor electrodes or ring electrodes. So generally they are used for the sensory nerve conduction study. This is ground electrode. So function of the ground electrode is to absorb all surrounding waves except biological waves. So whatever the extra waves they are present in the atmosphere like TV, radio, mobile, all this will be absorbed by this ground electrode. This is CMAP, that is compound motor action potential. It is also known as M wave. So here you can see this A, it is latency. This part is latency. This is depolarization. This is repolarization. This is hyperpolarization. Again coming to baseline. So this is latency. Latency means it is time taken by impulse to travel from stimulating point to recording point. Now from this point to this point, so this much it is your duration. And vertically peak to peak distance, it is our amplitude. Okay, it is our amplitude. This is for SNP, that is sensory nerve action potential. Now everything is same. This is latency, then this is depolarization, repolarization, hyperpolarization, again coming to baseline. Here the extra phase may be there, and it is because of local current flow, because this is sensory nerve conduction. Okay, testing. Now there are formulas. So for MNCV, it is distance between two stimulating point divided by proximal latency minus distal latency. So from this formula only, you can remember that we need at least 2 points of stimulation for calculating velocity. And as you can see in the formula, this is nothing but velocity means distance divided by time. That's it. Okay, physics formula. Velocity means distance divided by time. Yeah, so here also it is distance between two stimulating points divided by proximal latency minus distal latency. Okay, now again there will be question why we need 2 points of stimulation in MNCV. So the reason is, for example, if you stimulate median nerve from the wrist, okay, and you're recording from abductor pollicis brevis muscle, Clear. So this current will pass from neuromuscular junction as well as it will pass from muscle. So definitely when it passes from neuromuscular junction and muscle, so it is not purely part of nerve. It is part of this neuromuscular junction as well as muscle. So we will not be getting pure NCV. Clear. So we need pure nerve conduction velocity. So what we are doing, we are recording from the same muscle and we are stimulating at elbow. So what is happening? The common part of APB and neuromuscular junction will be excluded by this. So we can say that we will exclude the findings of neuromuscular junction and muscle by this subtraction. Okay, smaller component, okay, minus larger component. This is smaller component, this is larger component. So ultimately what you are getting, this much. Clear. So this is now here there was neuromuscular junction and muscle. Okay, you recorded like this, you recorded like this. Okay, now the larger minus smaller, so it will be like this. Okay, so this is now, this was neuromuscular junction and muscle. So in short, you can say that why we are taking 2 points of stimulation, to avoid the residual latency. Clear. And for SNCB, there is no neuromuscular junction, there is no muscle, so definitely it is distance between stimulating and recording point divided by latency. Latency means what? It is time. Okay, time taken by impulse to travel from stimulating to recording point. That's it. Parameters. So latency, it is time taken by impulse to travel from stimulating to recording point. So definitely latency more is problem. Clear. Like if you want to go from Rajkot to Ahmedabad and it takes 3 hours, so it is normal, we can consider. But instead of 3 hours, if you reach in 2.5 hours, so that is good, that is not problem. But instead of 3 hours, if you are getting 4 hours, okay, so definitely it is problem. So latency more is problem, latency less is not problem. Clear. It is suggestive of demyelination. Now amplitude. So amplitude is suggestive of number of axons. So more amplitude is good, less amplitude is abnormal. Velocity, so definitely good velocity, more velocity. Okay, it is not problem. Less velocity is problem. Clear. So latency more, it is suggestive of demyelination. Amplitude less, it is suggestive of axonal degeneration, and velocity less, it is suggestive of demyelination. Clear. Now from formula also you can imagine that velocity was calculated based on latency only, but velocity was numerator, latency was denominator. So definitely we can say that both are inversely proportional. So we can say that latency more and velocity less, both are suggestive of demyelination, and amplitude less, it is suggestive of axonal degeneration or axonal loss. Now these are different abbreviations, those are commonly used during reporting. So NCS, it is nerve conduction study. CNP, compound motor action potential. SNP, that is sensory nerve action potential. MNCV, so that is motor nerve conduction velocity. SNCV, sensory nerve conduction velocity. And MUAB, that is motor unit action potential. So if you find these abbreviations into your report, so you will be able to give full form. Now this was regarding NCV. Now what about FF? So here you can see it is motor nerve. Follow this pointer. So when you stimulate this motor nerve, so according to Bell-Magendie's law, impulse will be traveling in both the directions. So from this point of stimulation, it will be going towards distal side and it will be recorded as M wave. This is your M wave. Clear? So you can follow this pointer. It is your M wave. One impulse will go proximally also, but here the synapse will not allow. Okay, why? Because this is motor nerve. Clear? So here postsynaptic membrane will be here. Okay, so that is distally, and presynaptic membrane will be proximally. So definitely this impulse will not be able to travel from postsynaptic membrane to presynaptic membrane. It is not possible. So definitely the impulse will have to come back. Clear? So when this impulse come back, it will be recorded again as F wave. Clear? So F wave, it is purely for motor nerve, and if you suspect any problem at this proximal route, so it is suggestive of any radiculopathy or any neuropathy type of symptom. Now we have normal values of F wave latency. For upper limb it is less than 30 millisecond, and for lower limb it is less than 60 millisecond. So as you have observed, it is less than 30, less than 60 millisecond. Okay, it is normal. More than that, it is abnormal. Clear? So normal value is less than 30 millisecond for upper limb and less than 60 millisecond for lower limb. Now H reflex. So it is nothing but one type of the ankle jerk. So in ankle jerk, what we are doing, we are tapping with the hammer. Okay, we are tapping with the hammer. So what we are doing, we are stimulating muscle spindle. That muscle spindle will stimulate sensory component of the tibial nerve, and that will stimulate the spinal cord, again motor component, and lastly it will be stimulating gastrocnemius and soleus. Here we are bypassing muscle spindle. What we are doing, we are directly stimulating sensory component of tibial nerve from popliteal fossa, and it will be entering into the spinal cord. Okay, and will cross the synapse, will come back. Okay, and will be recorded from soleus. Okay, so it is nothing but ankle jerk. Okay, it is reflex arc of ankle jerk only, but we are bypassing muscle spindle. H reflex, it is given name H reflex because of its inventor. So that was Hoffman. It is also known as Hoffman's reflex. And why it is reflex? Because it is including synapse. You can see in this figure, it is including synapse. Clear? And this will be useful for radiculopathy as well as peripheral neuropathy. Now, this will be useful for limited use only. It may be useful for C5, C6, C7 radiculopathy and alpha S1 radiculopathy. Clear? And the thing, actually, it is limitation, but clinically also we are getting patients from this level only, like C5, C6 and C6, 7 radiculopathy, and in lower limb mostly it is alpha S1 radiculopathy. So in somehow we are not having more limitation. Otherwise, H reflex cannot be useful for all the nerve roots. Clear? But fortunately, H reflex utility is matching with our clinical requirement. Now it is elicited in soleus in lower limb, and in upper limb it is by flexor carpi radialis. Now the normal latency value, it is 29.8 plus or minus 2.74 millisecond. So if you add, so it will be around 32.5 millisecond. So we can say that more than 32.5 it is problem in lower limb, but not lesser latency is problem. Now repetitive nerve stimulation. So repetitive nerve stimulation, it is continuous stimulation 10 times. Then we will have to compare the first amplitude with fourth or fifth. So if there is reduction, okay, as the repetition increases, like first, second, third, fourth, fifth, so there may be decrement. Okay, so amplitude size will reduce. So that is nothing but showing of fatigue. That may be evident finding into the myasthenia gravis. Okay, so now there are various tests, like after exercise we have to record again, then we have to compare at rest and after exercise. So if there is a tremendous amount of fatigue in form of amplitude reduction, so definitely we can confirm the diagnosis of this myasthenia gravis, or we can support the diagnosis of myasthenia gravis. Clear? So that is nothing but repetitive nerve stimulation. Now EMG, so it is classified into three: insertional activity, spontaneous activity, and voluntary activity. Insertional activity means during the insertion of needle. Okay, it is continuous present tense. During the insertion of needle, whatever the activity is visible, it is known as insertional activity. Then spontaneous activity, so already the needle is inside the muscle. Okay, therapist or examiner is not moving the needle, as well as patient is not contracting muscle. So at that time, whatever the activity is seen, it is known as spontaneous activity. And third, it is voluntary activity. So definitely the needle is inside and I'm moving my muscle. Okay, I'm contracting muscle. So it is voluntary activity. Voluntary activity may be simple activity, that is minimal, that will be recruiting only slow twitch fibers. It may be with resistance, so that is known as interference pattern. Okay, so why we are offering resistance? To recruit fast twitch fibers also. So along with slow twitch, it will be having recruitment of fast twitch fibers also. Clear? So this is insertional, spontaneous, and voluntary activity. Now what is normal? So insertional activity, you will be having spontaneous potentials. Clear? It will be lasting for more than 300 milliseconds, and it is because of normal muscle membrane excitability. That is because of circulating acetylcholines. We are generally we are not giving more commands from insertional activity in clinical settings. Spontaneous activity means, as we discussed, no movement of needle as well as no muscle contraction. So ideally there should be logically. Okay, there should be electrical silence, means no electrical activity should be there. But if there is electrical activity, it is suggestive of signs of denervation. It is abnormal. So we can say that presence of spontaneous activity itself, it is suggestive of abnormality, except in two cases. Number one, patient is not relaxed. Why? Because of needle EMG, patient might be having some stress or anxiety, and patient will be contracting muscle. So definitely it will be recorded by machine. Okay. Second thing, if the needle goes inside neuromuscular junction. Okay, so in that case also it will start depolarizing nerve fibers, and there will be activity that will be visible. But other than these two cases, presence of spontaneous activity in form of anything, it may be fibrillation, it may be fasciculation, it may be complex repetitive discharge, it may be positive sharp waves, in any form, it is abnormal. They are suggestive of signs of denervation or signs of re-innervation. Now about the voluntary activity. So voluntary activity wise, we have various parameters. First is amplitude, so that is the vertical parameter. Then duration, so that is horizontal parameter. Frequency means how many times the potential is generated. Okay, it will be also having consideration of shape. So shape means whether it is biphasic or triphasic, means whether it is having two phases or three phases likewise. Okay, and there will be sound also. So sound here will be clear distinct thump type of this sound. Clear distinct thump means if something is falling from the height, so at that time whatever the sound occurs, it will be known as clear distinct thump type of the sound. Clear? So amplitude, so it is ranging from 100 microvolt to 2 millivolt. So generally amplitude is telling the density of muscle fiber, or clinically you can correlate it with MMT. So we can say that amplitude of the EMG, it will be giving you strength of the muscle. Then duration, so duration depends on size of muscle, but clinically we are not considering duration more for interpretation. But the thing is, duration will be considered along with amplitude for giving the size of this potential. Okay, so in that way only the duration will be helpful. Shape will be either biphasic or triphasic, and sound will be also changed, because if there is any type of the spontaneous activity, sound will be different, and the frequency will increase in most of the cases whenever there is any problem of signs of denervation, and interference pattern may range from 2 millivolt to 5 millivolt. So all these are normal parameters we need to remember, because if we know these normal parameters, then and then we will be able to understand what is abnormal. This is how MUAP will be looking like, that is motor unit action potential. So you can follow this pointer. This is one of the phase. This is another phase, second phase, and this is third phase. So phase means it will start from the baseline, again it will be ending on the baseline. This is also phase, so that is also starting and ending on baseline. But if we think of turns, so turns will be changing its direction without touching baseline. Clear? So here you can see, here it is changing its direction without touching baseline, so that is turn. So what is the meaning, or what is the clinical significance of this phase and turns? So if you are having two or three phases, so that is normal. But if you are having multiple phases or multiple uh, turns, so that is suggestive of lack of synchronicity. So I can explain like this: if all of the muscle fibers, they are firing together, so the phase will be like this. Okay, and if all of them, they are firing one by one, okay, so that is nothing but lack of synchronicity. So your amplitude will be lower and there will be multiple phases. Clear? So this is how clinical significance of phases and turns will be interpreted. Now, how this MUAP is formed? So here you can see this is A phase. Okay, so this will be formed, A will be formed whenever the impulse is coming towards needle. B phase will be formed whenever the impulse is passing under the needle, and C phase will be formed whenever the impulse is going away from the needle. So this is how MUAP is formed. Okay, now let us start with few reports, sample reports. Clear? So here I am enlarging the screen so that you can read even values of this report. Okay.
So first we will understand for motor nerve conduction study. See this report. Confused what to read? Let us start step by step. This is recording from left common peroneal nerve. So here we are testing left common peroneal nerve. Recording muscle is EDB, that is extensor digitorum brevis. This potential is created whenever we are stimulating common peroneal nerve at ankle. And whenever we are stimulating at ankle, so whatever the parameters are recorded, those are explained in this table. Now, if we are stimulating at head of fibula, so this type of the graph will be seen. When we stimulate at head of fibula, so all the parameters we are getting, those are recorded here. Now what is this? 3 millisecond, 5 millivolt, 84 milliampere. So 3 millisecond, it is known as sweep speed. Means what? Horizontally 1 centimeter is equal to 3 millisecond in this graph. Then comes to 5 millivolt. So 5 millivolt, it is known as gain or sensitivity. So vertically 1 centimeter is equal to 5 millivolt in this graph. What is 84 milliampere? So 84 milliampere, it is the intensity when this potential was captured. In the similar way, for second potential, that was because of stimulation at head of fibula. So it is 3 millisecond sweep speed. So that is horizontally 1 centimeter in graph is equal to 3 millisecond. 5 millivolt means it is vertically 1 centimeter is equal to 5 millivolt. And this potential is recorded at 64 milliampere. Now here you can see two vertical markers. You also observe two horizontal markers. So total we have 4 markers. First vertical marker. So it is giving value of latency. So in this example you can see it is 2.06 millisecond. Second vertical marker. So for that corresponding value you can see here, that is 9.11 millisecond. Now this is difference of these two, latency 1 and latency 2, or you can say it is the horizontal distance between two vertical markers. So it is nothing but 9.11 minus 2.06, so it is equal to 7.05. So that you can see in this example here as duration. So duration means it is nothing but it is horizontal distance between two vertical markers in this action potential. Now coming to two different horizontal markers. So vertical distance between these two horizontal markers, it is known as amplitude. So in this example you can see it is 4.35 millivolt. Now area means whenever you join all these 4 markers, two horizontal and two vertical, at that time whatever the area is covered by this rectangle or square, sometimes it is known as area. So in this example it is 9.55. Now when we are analyzing second potential, so that is because of stimulation at head of fibula, so you can see that latency is 7.01 and amplitude is 5.83. Now we have to identify the velocity. So for that we have to measure the distance between two stimulating points. That is commonly done with measure tape. So here in this example it is 210 millimeter. Generally we are measuring in centimeter, so that is 21 centimeter when we are performing test, but machine is asking in millimeter. That's why instead of 21 centimeter we are writing 210 millimeter. Now we have to identify the difference of proximal latency and distal latency. Clear? Now proximal latency, so definitely it is because of stimulation at head of fibula, and distal latency it is because of stimulation at ankle. Latency means it is time taken by impulse to travel from stimulating point to recording point. So here proximal latency it is 7.01 and distal latency it is 2.06. So when we go for subtraction, so it is 7.01 minus 2.06. So it equals to 4.95. So that is already mentioned here as difference of latencies, proximal latency and distal latency. Now we have formula for calculation of motor nerve conduction velocity. So it is distance between two stimulating points divided by proximal latency minus distal latency. Let us put the value. So it is 210 divided by 4.95 or 96. Then value will be calculated. It is 42.42 meter per second. So this is how we are calculating motor nerve conduction velocity. Now let us understand for sensory nerve conduction study. This is sensory nerve action potential. So here you can see latency 1 marker. So it is at 1.95 millisecond, that you can see in table also. This potential is recorded from right ulnar, as you can see in left upper corner, and just by the side of it you can see that it is recorded from 5th digit. So that is little finger, that is supplied by ulnar nerve, okay, for its sensory distribution. Now amplitude, so that is vertical distance between two horizontal markers, so it is 21.32 microvolt. Generally for motor nerve conduction, amplitude is coming in millivolt, and for sensory it is coming into microvolt. Now distance between stimulating and recording point for sensory nerve conduction study. For motor nerve conduction, it is distance between two stimulating point, when for sensory it is for distance between stimulating and recording point. So here it is 120 millimeter or 12 centimeter. Latency is already there, so that is 1.95. Now we have formula for the calculation of sensory nerve conduction velocity. So that is distance between stimulating point and recording point divided by latency. Let us put the value. 120 divided by 1.96. Answer is 61.54. So that is already calculated SNCV, that is sensory nerve conduction velocity. For motor nerve we need at least 2 points of stimulation. Why? Because the common component that comes in both the stimulation, that is neuromuscular junction and muscle, we need to exclude by subtraction. Why? Because it is including neuromuscular junction and muscle, and we need only nerve conduction velocity. But in case of sensory, there is no neuromuscular junction, there is no muscle. So whatever we are getting by the calculation for distance divided by time, it is nothing but velocity only in nerve. Now these are all different values for different nerves. You can have screenshot of this, and you can have for your record. So in this screen you can see for median and ulnar, you can see in table latency, amplitude and velocity. Latency, as we discussed, it shows the time taken by impulse to travel and to reach from stimulating to recording point. So if you have more latency, it is problem. It is suggestive of demyelination. Amplitude, so amplitude is giving you number of axons. So amplitude less is problem. Less amplitude is suggestive of axonal degeneration or axonal loss. Now conduction velocity, so NCV, that is calculated from latency only, obviously as per formula. So if the latency is more, demyelinating changes are there. In formula of NCV, latency is denominator. So here there will be inverse relationship. So latency more is suggestive of demyelination, NCV less is suggestive of demyelination as per formula. So you can have screenshot of this median and ulnar nerve. You can have for radial, long thoracic, axillary, musculocutaneous and suprascapular also. You can have for peroneal and tibial. So all these are motor nerve conduction study normal values. Now for sensory nerve conduction study normal values, you can have median, ulnar, radial, okay, and lateral and medial antebrachial cutaneous nerve. Then other are of lower limb, superficial peroneal, sural, medial plantar, lateral plantar and posterior cutaneous nerve of thigh. Now we will see the different examples of this report. So let us start with conduction block. So you can see that this patient is having surgery over the calf region. So it is possible that now may be damage between the knee and ankle. So what will be the finding in NCV? Let us see. Now this recording is for posterior tibial nerve. It is recorded from abductor hallucis muscle. It is by stimulation at ankle as well as at popliteal fossa, that you can read in the report. Now we have to compare the amplitude. Okay, so if we stimulate at ankle, amplitude is 15.21, and if we stimulate at popliteal fossa, amplitude is 3.33. So here you can see that amplitude, because of stimulation at popliteal fossa, it is quite less as compared to amplitude whenever we are stimulating at ankle. So 3.33, definitely it is less than 50% of 15.21. So if you have amplitude reduction more than 50%, okay, whenever you are stimulating proximally, as compared to distal amplitude, your proximal amplitude is less than 50%, or we can say that amplitude reduction is more than 50%. So that is suggestive of conduction block. Okay, let us understand with physiology also. For example, as we have seen that patient was having surgery in the calf region. So when you stimulate at ankle, so that part will be normal. But when you stimulate at popliteal fossa, so impulse will have to travel from this region where surgery is done. So definitely the amplitude will be less. So here the distal component is normal. But whenever the impulse is coming from proximal region, so it has to pass from this damage. So there will be amplitude reduction. So in short, if your amplitude, because of stimulation at proximal side, if it is reduced more than 50% as compared to amplitude because of stimulation at distal side, it is suggestive of conduction block. Now let us see for facial palsy. So in this you can see that patient is having one side palsy. Now this is report for right facial nerve recorded from nasalis muscle. So we have to see the amplitude, so that is 2.72. Right side is normal for this patient. So 2.72 millivolt it will be considered as reference value. Now we have to compare this reference value with left side, that is affected. So on right side, that is normal side, it is 2.72 millivolt. On left side it is 0.66. So definitely it is lesser than 50%. So on the affected side, amplitude is lesser, more than 50% as compared to amplitude on normal side. In conduction block, we were comparing proximal and distal amplitude. In Bell's palsy or facial palsy, we are comparing amplitude of right and left side. So here affected side should be having amplitude lesser than 50% as compared to amplitude of normal side. Okay, in this also we have classification. If the amplitude is less than 10%, recovery may happen within 6 to 12 months. If the amplitude is coming 10 to 30%, recovery may take within 2 to 8 months. And if the amplitude is more than 30% but less than 50% as compared to normal side, so the recovery will be very good and you will be having recovery in less than 2 months. Now carpal tunnel syndrome. So it is very interesting. Here in this picture you can see that median nerve is getting compression, okay, from this carpal tunnel. So it is getting compressed. Now let us see the report. So here it is taken from right median nerve and recording muscle is abductor pollicis brevis, and it is by the stimulation at wrist as well as elbow. So as you can see, in latency 1, 6 millisecond it is latency. Ideally it should be less than 4.4 millisecond whenever you are stimulating 3 centimeter proximal to distal crease of wrist. Clear? So normally it should be less than 4.4 millisecond, but for carpal tunnel it should be more than 4.4 millisecond. Is this clear? So here we are getting 6 milliseconds, so definitely it is more than 4.4 millisecond. So it is suggestive of carpal tunnel syndrome. Now along with this we have to see the amplitude also. So amplitude is 5 millivolts, so that is normal. Okay, and velocity is 63.64 meter per second, so that is also normal. Why? Because here the stimulation is at wrist, but 3 centimeter proximal to distal crease of wrist. Clear? So actually we can say that stimulation is proximal to compression. Another stimulation, that is at elbow, so definitely it is also proximal to compression. So here both the stimulating points, they are proximal to compression. Okay, and as per formula of MNCV, it is distance between two stimulating points. So when we compare or when we calculate this distance between two stimulating points, so it is pure now, and that will be 3 centimeter proximal to wrist. So that is also 3 centimeter proximal to compression. So definitely now conduction velocity and amplitude will be normal. Latency, why it is affected? Because it is the time taken by impulse to travel from stimulating point to recording point. Recording point is abductor pollicis brevis. Stimulating point is 3 centimeter proximal to distal crease of wrist. So impulse will have to travel from compression. That's why the latency is prolonged. Now we have to compare the values of median nerve along with ulnar nerve also of same side. Why? Because only latency prolongation in median nerve, it is not sufficient to prove that it is carpal tunnel syndrome. It may be in case of polyneuropathy also. But here we are proving that right ulnar nerve is normal. So it is not case of polyneuropathy. Clear? So we have to prove that right ulnar nerve findings, they are normal. Now here we have to see the latency for right ulnar nerve. It is 2.77 millisecond. Now there is one formula. So we have to give the difference of this latencies of median and ulnar nerve. So ideally in normal individual the difference should be less than 1.1 millisecond. For carpal tunnel syndrome, this difference of distal latency of median motor nerve and distal latency of ulnar motor nerve, it should be more than 1.1 millisecond. So in our patient it is 6.00, so that is nothing but latency of the median nerve, that already we saw in the previous page, and latency of ulnar nerve, so that also we have in this figure. Okay, so 6 minus 2.77, so difference is 3.23 millisecond. So normally this difference should be lesser than 1.1 millisecond. For carpal tunnel syndrome it should be more than 1.1 millisecond, and we have 3.23 millisecond in this example. So definitely this patient is suffering from carpal tunnel syndrome. Another criteria, we have to go for sensory nerve conduction study also. So here it is right median sensory nerve, that is recorded from second digit, that is nothing but index finger, where there is supply of median nerve. Here the latency is prolonged, that you can see amplitude is also reduced and velocity is also reduced. Why? Here the stimulation is 3 centimeter proximal to wrist and recording is again distal to wrist. So stimulation is proximal to wrist and recording is distal to wrist, that is from first digit. So definitely the impulse will have to travel from compression. And for sensory nerve conduction study we are not getting second point of stimulation. So here this is the only pathway that we are assessing. Okay, the point 3 centimeter proximal to wrist crease, okay, from that point to index finger. So definitely your latency, amplitude and velocity all will be affected. Now we have to prove ulnar nerve here also normal, because if the ulnar nerve is also affected, it is not carpal tunnel syndrome, it is case of polyneuropathy. Okay, so here again the difference will be having some role. Why? Because median is affected, ulnar is normal, so this difference will be always more. So for this sensory nerve conduction study, what is the difference that is allowed? So the distal latency of median sensory nerve minus distal latency of ulnar sensory nerve, normally it should be less than 0.2 millisecond. But for carpal tunnel syndrome, it should be more than 0.2 millisecond. In our patient, median nerve latency, it was 4.93, obviously of sensory median nerve, and sensory ulnar nerve latency, it is 1.95. So 4.93 minus 1.95, it is equal to 2.98 milliseconds. So definitely it is more than 0.2 millisecond. So it is again supporting the diagnosis of carpal tunnel syndrome. Now foot drop. So here you can see in one foot the dorsiflexion is lacking. So let us see with the report. So here you can see this report is for posterior tibial nerve, recorded from which muscle? Abductor hallucis muscle. Here you can see that latency, amplitude and velocity, all these findings are normal. Now let us go for peroneal. So this is report for left common peroneal nerve, recorded from extensor digitorum brevis. So here actually the potential itself, it is not generated. So it is suggestive of complete axonal degeneration in common peroneal nerve of left side. So we have to cross check with SF also, or opposite also you can do. Whenever you are having any case in which the surge Faradic current is not responding, so no need to send that patient for NCV. Why? Because if the surge Faradic current is not responding, definitely the potential in NCV will be also absent. Now in this patient only we have abnormal findings in common peroneal nerve. Now if you have also abnormal findings in posterior tibial nerve, so that is here, so if this is also affected, okay, and this common peroneal nerve, that is also affected, so in that case what you need to do, you need to check sciatic nerve also. But in this case it is not required. Why? Because the tibial nerve is functioning properly, only common peroneal nerve is not functioning properly. Now in case of polyneuropathy, polyneuropathy means, poly means multiple, okay, and neuropathy means pathology of nerves. So multiple nerves will be affected, like in case of diabetic polyneuropathy, alcoholic polyneuropathy, in case of Guillain-Barré syndrome, all these are examples of polyneuropathy. So here you can see the report of posterior tibial nerve, recorded from abductor hallucis muscle by stimulation at ankle and popliteal fossa. So here the amplitudes, they are normal, okay, so they are marked with green color, but velocity is reduced, so that is marked with red color. Let us see for other nerve. So you can see that right median nerve, so amplitude is also reduced and velocity is also reduced, okay. So this is nothing but amplitude reduction, it is suggestive of axonal degeneration or axonal loss, and velocity reduction, it is suggestive of demyelination. So it is suggestive of axonal degenerative and demyelinating type of neuropathy. Now what about this? So that is radiculopathy. Radiculopathy means throughout nerve is not having any damage, but it is getting compressed somewhere, okay, it is getting compressed somewhere. Let us see. So for that we have F wave. So you can see that on the left side you have M wave, okay. After that on the right side in the graph you can see you have F wave. So M wave, they are seen at the gain or sensitivity of 5 millivolt, and F wave, they are seen with the gain or sensitivity of 1 millivolt, and this whole graph, it is at the sweep speed of 10 millisecond per division. Here you have to see the F mean. So F mean here it is 54.69. So for upper limb, F wave latency should be less than 30 millisecond, and for lower limb F wave latency should be less than 60 millisecond. So here this is for posterior tibial nerve, so definitely it is lower limb. So for lower limb, maximum value of F wave latency should be 60 millisecond. So here it is 54.69 millisecond, so definitely it is lesser than 60 millisecond. So here it is normal. Now here you can see it is H reflex, okay. So on left side of the graph you can see M wave, and on the right side in the middle part of the graph you can see H. Okay, so M wave, it is seen at the gain or sensitivity of 5 millivolt, and H, it is seen at the gain or sensitivity of 500 microvolt, and whole graph is with the sweep speed of 10 millisecond per division. So here H latency you have to see, it is 35.68 millisecond. So generally the maximum allowed value for H reflex when it is recorded from soleus, it is 32.5 millisecond. So definitely 35.68 millisecond, it is more than 32.5 millisecond, that is maximum allowed latency. So here it is suggestive of radiculopathy. Now let us see for EMG. So EMG, that is electromyography, so it is having insertional activity, means whenever the needle is going inside or getting inserted inside the muscle, at that time whatever the activity is seen, it is known as insertional activity. Another is spontaneous activity. So needle is already inside, therapist or examiner is not moving the needle, as well as patient is not contracting muscle, so it is known as spontaneous activity. Voluntary activity means needle is already inside the muscle and patient is moving the part or body part, so the muscle is contracting. In that case it will be with active movement, so that will be minimal type of the voluntary activity, and it will be with resistance also. Why we are offering resistance while doing EMG? So that is to recruit the fast twitch fibers. So whenever we are recording with resistance, it will be known as maximal type of the voluntary activity, and commonly it is known as interference pattern or IP. Now all these parameters you have to remember, you don't have any choice. Amplitude is ranging from 100 microvolt to 2 millivolt. Duration is from 5 to 15 millisecond. Rise time not having much clinical significance, it is lesser than 500 microsecond. Shape of this MUAP, that is motor unit action potential, may be diphasic or triphasic, and sound will be clear distinct thump as if something is falling on a hard surface, okay, or something is having free fall, and whenever it touches the ground, so whatever the sound comes, it is known as clear distinct thump. Frequency for normal individual, it is ranging from 30 to 50 per second, and in case of interference pattern, amplitude may reach up to 5 millivolt starting from 2 millivolt. Sometimes satellite potentials will be seen, so those are nothing but late and unstable potentials. Now in case of signs of denervation, when your nerve is getting degeneration, at that time what will be the finding? So presence of spontaneous activity, generally there is electrical silence. Okay, if your needle is going inside the neuromuscular junction, then even in normal individual you will be getting spontaneous activity. Second option, your patient is not relaxed, so in that case also, in case of normal individual also, you are getting spontaneous activity. But in all other cases, if the spontaneous activity is coming itself, it is abnormal, so ideally there should be electrical silence. Clear? So if you have presence of spontaneous activity, for example fibrillation potential, positive sharp wave, or fasciculation potential, or any other type of the spontaneous activity, itself it is abnormal. So in short, presence of spontaneous activity itself it is abnormal. It is giving signs of denervation. Some authors, they are also telling that in presence of signs of reinnervation also, this spontaneous activity will be visible. Now generally it takes time like almost 3 weeks to appear for this spontaneous activity, okay, and in upper limb even this abnormality is existing after 6 months in upper limb, and after 18 months in lower limb spontaneous activity will not be visible. So we can say that before 3 weeks, even if the patient is having abnormality, spontaneous activity will be absent, and for upper limb after 6 months, and for lower limb after 18 months, okay, even patient is having abnormality, spontaneous activity will not be visible. In all other cases, presence of spontaneous activity itself it is abnormal. It is either signs of denervation or signs of reinnervation. Now in case of myogenic lesion, So let us see this voluntary activity. So here you can see it is recorded from right tricep, okay, with the sweep speed of 10 millisecond per division, means 1 centimeter horizontally it is equal to 10 millisecond, and sensitivity or gain it is 100 microvolt per division, means vertically 1 centimeter it is equal to 100 microvolt. So here also you can see the same thing, but the potentials they are very small, but it is recorded from frontalis, so it is fine, because generally we are having 100 microvolt to few volts, okay, so generally up to 2 millivolt. So here you can see it is more than 100 microvolt, it is more than height of 1 centimeter, so definitely it is more than 100 microvolt. In case of this right tricep, you can see that they are occupying 5-6 squares vertically, so it is near about 500 microvolt to 600 microvolt. And in case of this frontalis, they are hardly occupying 1 or more than 1.5 square vertically, so they are hardly of 1.5 centimeter or more than 1.5 centimeter, but definitely less than 2 centimeter. So we can say that here the amplitude is ranging from 100 microvolt to 200 microvolt. This is example or picture of interference pattern. So this is again for right tricep, and sweep speed is 100 millisecond per division, and sensitivity it is 100 microvolt per division. So here you can see that many squares they are occupied, and generally the one square it is equal to 1 centimeter. So here we can say that this interference pattern on some places they are occupying all 10 squares, so it is reaching around one square it is equal to 100 microvolt per division, means 1 centimeter 1 square it is equal to 100 microvolt per division, okay. So it is occupying near about 10 squares, so it is reaching around 1000 microvolt per division or 1 millivolt per division.
Now, I hope that you have understood this interpretation, but this is not just end of electrodiagnosis interpretation. This was just base how to start interpretation of EMG and CV reports. Now, you will be learning by repeated interpretation of different reports. Okay, so just discuss, just try to find out the answer. If you're finding any new terminology in the report, or if you are confused, you can ask any expert, okay, or even me later on, okay. And for today's session, if you have any doubt, you can mention into the comment box and we will be discussing. And after this lecture is over, feedback form will be shared to you in comment box only, so kindly fill the feedback. And one more time, I would like to thank RK University for giving me this opportunity for conducting this webinar of electro